Hi. Good afternoon. Good afternoon. How is everyone? Happy Monday. Happy end of first term. Yay. Hi. Still taking classes. Right. So thank you for joining us today. We're here for the Department of International Health seminar series, which we are kicking off, and we're very excited that our first focus today is going to be from the core of our doctoral students. We've been able to identify a doctoral student across each of our programs that is really going to talk about their work. They know that this is a 5-minute presentation. I will set my timer. These are lightning talks. The idea behind this is really to spend a little bit of time afterward for people to have a discussion and be able to talk to the doctoral students after, hence why we're going to kind of move people along and keep them on the lightning rounds of 5 minutes. And I'm sorry, I didn't introduce myself. I think I know most of you. My name is Rupali LeMay. I'm an associate professor here and the associate chair for research. So Brandon and I are very excited to be able to kick off this seminar series today, and we will be having these hopefully monthly. So if you are interested in presenting, please do feel free to reach out to one of us. With that, I will go ahead and get us started. One other logistical thing that I want to make sure everyone knows, we'll let each student presenter go. We won't do any questions in between. We'll do questions all at the end. So hold your questions, write them down. They're very excited to talk about their methods. Yes. But please hold them until the end. Okay, so I'm going to have Brooke come on up first. She's going to kick us off.
Okay, hi everyone. My name is Brooke. Okay, great. So I will be talking about my work titled Closing Equity Gaps in Immunization and Primary Care Systems. I'm in the Health Systems program, and I'm really grateful that this work is supported by Dr. Chizoba Winodi and Dr. Brian Patnode. So I'll be focusing on barriers to reaching vaccine zero dose and multi-zero dose children. So I'll explain what I mean by that in a second. So just by some background, zero-dose children are defined as those who haven't received any vaccination. So worldwide, there were about 14 million zero-dose children last year. And interestingly, there are more zero-dose children than there are under-vaccinated children, meaning that our routine immunization systems are good at reaching children multiple times, but they're not so great lately at expanding those services. So some of the work that I want to do kind of builds on this momentum and energy in the global vaccine space to look at zero dose status, look at children who are zero dose, or what I'm calling multi-zero dose, for several services. So my first aim looks to define and describe this concept of multi-zero dose status, and that will be through indicator development. And also begin to understand how health systems factors are related to this. So I'll be working to develop a database for this and doing some simple descriptive analyses. I then want to map the areas with high levels of zero dose status and also do a multi-level model to begin to understand and quantify some of these factors, like these community and health systems factors I'm bringing in the first aim. And then lastly, and I'll focus a bit on this today, I want to get an understanding of how we can better optimize that first point of contact children have with the health system at birth dose vaccination through a case study in Madagascar. So just very briefly, I know this is kind of a new concept, this multi-zero dose status, but I want to look to really focus on the subset of the most vulnerable households and families that are truly zero dose or haven't received several services. So I haven't done this yet, but I'm going to work on developing indicators based on existing data sources. And then what I'll share today is some of the preliminary findings from my key informant interviews in Madagascar with caregivers, community leaders, providers, and managers in areas with high levels of zero dose status. So just to very briefly show, I'm a health system student, so I have to show a framework. Here is the framework we worked to develop, centering birth dose in the center, showing that it's directly impacted by experiences mothers have with the care system, and then directly impacts the services that children have. This is also really influenced by larger household level factors and health systems factors that we'll have in the models in the first two aims as well. So now this gets into our situational analysis done with DHS data in Madagascar. So we understand that zero dose or children not vaccinated at birth are likely to have limited access to health services. Their mothers have limited access to services. About 85% of them are born at home. We kind of expected this. But what we didn't expect to see is that there's still a substantial proportion of these children who have strong connections with the health system. Their moms, about a third of their moms have had at least 4 A&C services, but somehow that hasn't translated into their child getting vaccinated at birth, which is a little bit perplexing. We also see that children who are not vaccinated at birth are much, much more likely to become 0 dose. So about 85% of the children who don't receive any vaccines at birth become 0 dose. And I kind of look at this as an opportunity to reach children, especially with all this energy around 0 dose status right now. But what's a little bit conflicting is that we're not yet doing a good job in turning this point of contact into a kind of strong contact with the immunization system. Of the children who receive only 1 vaccine in Madagascar, for whatever reason, about 2/3 of them only received BCG and then never came back for another vaccine. So then now here is the findings from my key informant interviews. So the last was a situational analysis, and now this is from 87 key informant interviews. Some of the constraints to stronger birth dose vaccination platforms are kind of put into these 5 areas. The first one is vaccine availability. There were major stockouts of the BCG vaccine, and there's also vial constraints. So the vials have 20 doses, and healthcare workers don't want to open them if they only have 1 child. So this really, really disproportionately affects children in remote rural areas as well. Policy, we also see that as they're moving more towards facility births, which is great, there isn't a policy and there isn't something in place to consider those born at home. So as we make improvements there, we need to make sure that we're not kind of widening the inequity gaps among those born at home. We also have financial and human resources, so making sure we're better able to engage community agents who really know the communities that they work in. Costs to family, both experienced and perceived costs, and going to facilities to have their children to deliver, also to receive vaccine services like cost of transport. Almost done. And then awareness too, there's low awareness among birth dose vaccination kind of compared to the rest of the immunization in the schedule. So just kind of now going back to the overall thesis, this work really aims to develop a new indicator so we can better understand that most vulnerable subset that we're just consistently not reaching with the health service, with the health system. It also aims to understand some of the health systems factors, but also quantify those factors. A lot of times we talk about community level factors, or we talk about household level factors, which really puts the onus on families and on mothers especially. So being able to kind of see where health systems come in, and then also identify solutions to really strengthen that first contact with the health system. So I'm very grateful for everyone's support. Thanks very much.
Oh, it doesn't work? Okay. Hi, everyone. My name is Arman. I'm in SBI, Social and Behavioral Interventions. And the topic I want to talk to you about today is my project, which is What About the Community? Examining Clean Cook Stove and Fuel Research in the Peruvian Andes. A bit of background about this topic. So according to the WHO, there are 2.4 billion inefficient cook stove users worldwide. What is an inefficient cook stove? An inefficient cook stove is one which usually burns biomass of some kind, whether that's wood, animal dung, crop residue, or coal. Use of these cook stoves is estimated to kill about 3 million people annually due to cardiopulmonary illnesses. And since about 2010, there's been a boom in trials being conducted to understand the impact of cleaner cooking technologies to mitigate the health effects of household air pollution. Earlier trials that were conducted in approximately 2010 showed some promising results regarding the impact of cleaner stoves and fuels, but there still remain some informational gaps. And intervention use of these cleaner stoves and fuels was not sustained for a long period after the trial ended. Newer trials have also tried to fill some of these informational gaps, but have also simultaneously struggled with post-trial disuse. Ethnographic work that's been done in the space has shown that community engaged approaches have typically been beneficial or important for sustained use or sustained involvement in the intervention, the design of the intervention itself. So my study sought to understand how Clean Cook Stove trial participants participating in a household air pollution project in the rural Peruvian Andes were being engaged, and to identify the shape of participatory approaches for future research. So I chose an ethnographic approach for my work. I was following a trial studying the impact of measures to mitigate household air pollution called HAPPEN on pregnant women and children. Will Checkley is the co-PI on that. And it was an NIH combo Gates CCA funded project. So my aims in this space were to conduct a historical examination of the use of participatory approaches to really understand historically how communities were engaged in research of this nature. And for that, I have been using archival analysis. For my second aim, I wanted to explore the perspectives of the investigators in research and field workers in the research to really understand how they went about implementation and designing the project to engage with the communities that they ultimately engage with in Puno. For this, I chose to use IDIs or in-depth interviews and participant observation. And finally, my third aim was to understand the experiences of the trial participants themselves and really understand how they felt about the engagement they had with the study, as well as while the study was ongoing, as well as in the follow-up period that I had the opportunity to observe. And my main method in this was to use in-depth interviews. I gained IRB approval for this project in late May or early June this year, and I went to Peru in early July. I chose an ethnographic approach because it offered me different insights than a standard qualitative approach would have presented. And I felt that really understanding the structure of the relationships between participants, between the participant and the study itself was essential for us to really understand the nature of engagement and how that how those relationships formed and reformed to be able to generate that space of participation. I have some preliminary results from a little bit of some of the work that I did earlier this summer. The first thing I found was that initial participant distrust, and there was a lot of distrust almost universally, usually required considerable attention of the field workers themselves to mitigate some of that distrust. So they had to spend a lot more of their energy and time to work through that, through some of those elements of distrust. Field workers also developed strong relationships or strong personal bond with a lot of the community that were part of the trial. And those bonds actually created long-lasting friendships that went well beyond the study itself, where a lot of field workers said that they would often advise communities or the participants on life events and other life challenges as they arose. And one of the last few things that came up was all participants really wanted to be more engaged in the research themselves. They really wanted to understand the project more deeply. Many of them had a very rudimentary understanding of what was being researched. But almost universally, all participants said that they wanted to know what the results of the research was. Some next steps, I will be looking at essentially aspects related to the relationship between the partners of the participants and how those partnerships play a role in kind of defining what the community of intervention should be or is in this case. I also want to understand priority setting amongst these communities, amongst these participants. What is the priority to them? How do they set it? As well as trust. And for this, I'm going to be digging a little bit more deeply into it in the coming few months. So some of the conclusions from this I have, we were asked to identify some conclusions. Mine are identify who we're engaging with. What is the community? Well, who are we talking about when we randomize people into control intervention groups? And what does that mean to the community itself? If we're talking about just the individual, is it the individual themselves that are the most important unit of randomization, or is it the household, or is it some other thing? How do the communities understand that? Develop processes for determining priority interventions with these communities. So having interventions that are more responsive to their needs, as well as mapping out spaces for future work. When we're thinking about designing interventions, we're thinking about designing trials or implementing trials, what role could the community play in those trials, in the design of them, as well as the dissemination of those trials. I'm going to skip ahead to acknowledgements since we're well out of time, but I just want to thank the program in Latin American, Caribbean, Latinx Studies for their funding support, as well as Center for Qualitative Studies in Health and Medicine, as well as my thesis advisory committee, the HAPPEN investigators who've been absolutely tremendous in opening their doors for me and allowing me to follow their research project, to the folks in Lima and Peru who really gave me a lot of their time and made this project entirely possible, as well as everyone here and my own family, who I will lean on for more support going forward. Thank you.
All right. Hi, my name is Molly. I'm a third-year student in the GDEC program, and I'm going to take you on kind of a whirlwind tour of my work on maternal immunization, highlighting some of the parent studies ongoing in this area, and all of this with an eye toward future vaccines coming up for use in pregnancy. So just to start off speaking the same language, when we talk about maternal immunization, we're referring to the use of vaccines given to individuals during pregnancy or lactation with an aim to provide some protection to that individual and to confer some protection to the developing fetus or newborn through passive antibody transfer. There are only a few vaccines currently recommended in pregnancy, although there are more coming in the pipeline. And a lot of these holdups on increasing access stem from the lack of clinical trial data in pregnancy. So very frequently, pregnant individuals are excluded from participation in clinical trials, which means that down the line, when we make policy and program decisions, we're relying on later observational data instead of these controlled studies. And that also means that those introductions tend to be quite a bit later than the general population. There's a good reason for that. It's a very well understood sense of caution, but with so many vaccines coming up for use in pregnancy or for conditions that are particularly serious in pregnancy, now is a really important time to start to address this question and better understand how decision makers, providers, and community members perceive maternal vaccines and how we can navigate the emergence of data in this space. So my work is with a parent study called MIRI, which is led by Ruth Karen and Dr. Lemay here. And we focus on 3 different areas. So my first aim looks at a cross-sectional survey of pregnant and lactating people in Kenya in 2 counties, with an aim to understand how they perceive RSV vaccine and RSV disease, and then maternal immunization more broadly. For this particular aim, in addition to some descriptive analyses, doing a latent class analysis to identify if there are emerging groups that might help inform strategies for intervention later on. The second aim switches the focus to providers and group B strep, which is another really important, though a little bit farther out in the pipeline, vaccine for use in pregnancy. And we focus on providers here because it's not a very well-known disease in the public, so important to understand how they make decisions about recommending. This one is a multi-method approach, so we're pairing a cross-sectional survey with a set of interviews with providers who are generally involved in supporting women during pregnancy. And then the last aim looks at that question of the availability and the use of clinical trial data and broader evidence in informing these decisions to use maternal vaccines in the existing program. So we'll be doing in-depth interviews with decision makers ranging from ministry and regulatory officials to providers and professional organizations to understand how they navigate the availability or the lack of clinical trial data on vaccines in pregnancy when they're crafting policies and programs, and then how we can package all of this together to proactively sensitize communities and systems to be ready for maternal vaccines when they come. The approaches are intentionally multi-method because this is a really new space and there is not a lot of awareness about these upcoming vaccines and even about the diseases specifically. Latent class analysis we've selected because it gives us a chance to empirically classify participants based on their survey results into groups that might help us better tailor programs and policies moving forward. It's been used quite a bit in maternal immunization, but it's generally been done in high-income countries, especially the US. And there are very few, if any, that look at this question in a post-COVID world where we have a new maternal vaccine being used. On the qualitative side, as I mentioned, this is a new frontier for us. And so these new emerging vaccines that were developed specifically for use in pregnancy open up a lot of new questions. An inductive approach here, leveraging a couple different methodologies, is a great way to really make sure this is respondent driven and is guided by the language and the perceptions of our participants rather than us kind of imposing a framework on them. So where am I? I'm a little bit behind the team that you just heard, but currently in the throes of analysis for both of the first two aims. We collected data for these aims about a year ago in Kenya, and so we're completing some additional analyses in addition to the parent study work. And then in the spring, we'll really move forward with the third aim of diving into these clinical trial and evidence questions. Across the board, this project is really prioritizing dissemination, so making sure that all of this work can be shaped and handed back over to stakeholders in country and at the global level to better respond and prepare for these vaccines coming up soon. So early conclusions, the hope is that with new RSV, GBS, TB, and other really important vaccines, either designed for use in pregnancy or for illnesses that are really important for pregnant individuals and newborns, better understanding the community's existing perspectives, how providers navigate the available evidence, and how policymakers will grapple with this sudden availability of clinical trial data they've never had before. Hopefully this can really help to refine the processes in place and better prepare systems so that we don't rely on this idea that once the vaccine is there, everybody will roll it out and accept it. So again, hopefully this will provide formative work to flow into broader maternal vaccine activities. So just to close, again, this is part of the MIRI study, which is a two-country study located in Kenya and Bangladesh, but this is focusing on our Kenya work. And as Arman just said, also grateful for some funding support to conduct these activities. Thanks.
All my things. Keep me on track. Okay. All right. Hi, everyone. My name is Audrey Buckland, and I'll be presenting a little bit on my dissertation research, which is understanding how to reduce breastfeeding inequities among Latine families in the U.S. Mexico border region of Arizona. And my advisor is Dr. Kristen Hurley. So I just want to start with the importance of breastfeeding to sort of ground the relevance of this research. But first, I want to note that I'm using the words breastfeeding and women here because those were the terms used by study participants. But it's important to recognize that not all people who breastfeed or chest feed identify as women. Breastfeeding has beneficial impacts on infant and maternal health, so much so that the World Health Organization and the American Academy of Pediatrics recommend these optimal breastfeeding practices highlighted in the yellow box here on the screen. Despite the well-documented benefits of optimal breastfeeding, current practices in the US are still lagging behind public health goals, and disparities still exist in breastfeeding practices. Those disparities are greatly driven by sort of poverty, structural racism, predatory behavior by commercial formula marketing companies, lack of supportive policies, and inequitable accesses to services and resources, all of which we see at the research site for my dissertation in Arizona, sort of pictured here. It's like a bird's eye view of where I was working. Right. So the dissertation is situated in, again, a rural county in southeastern Arizona that shares its southern border with Mexico. The U.S. Mexico border region is characterized by a really unique geographic, social, cultural, economic, and policy forces that shape the health of its residents. And in this particular area where I was working, it's really common for people to sort of be flowing, like driving back and forth across the border to maybe go to work, to visit family, to go grab dinner, to go see the doctor. So it's a very dynamic space where people are really flowing constantly within the day even. This research was conducted in partnership with the Federally Qualified Health Center in a border town. And we recruited pregnant and postpartum participants who identified as Hispanic or Latina to be interviewed. We also recruited health and nutrition professionals and providers for key informant interviews. So those would include like lactation consultants, nurses at hospitals, WIC staff, pediatricians. The approach to my dissertation was very iterative, and I would call it mixed methods, as each step really built on the next and was greatly informed by sort of the previous methodologies that were used. And there was a real motivating question here that was the driving force for the selection of methods. And this was brought up by the pediatricians that I was working with. And they were really wondering, why are most of the babies that we're seeing not exclusively breastfed in the first even 2 months and even earlier than that? So it was sort of strategic to understand that question. So I have 3 aims. I'll go through these very quickly. The first is to characterize prenatal intent to breastfeed. The second is to identify factors associated with infants receiving any human milk and exclusive human milk during the first 6 months. And the third is to examine facilitators and barriers to optimal breastfeeding practices. The first and third aims used qualitative methods, so semi-structured interviews, key informant interviews, and the middle aim there was quantitative, and it was a secondary data analysis of a limited clinical data set to sort of pull it all together. So I'll just share a few preliminary results here corresponding to each aim. So I just wanted to pull some quotes and show you a quick figure here because there's so much to cover. But with the first aim, which was looking at breastfeeding intent, one participant told us, my parents kind of want me to go more to formula because they see how much I've been struggling with pumping and how stressful it's been for me, but I don't want to. So this is trying to understand sort of intent to feed during pregnancy, and then what happens going beyond that in that trajectory. And we found that a lot of women expressed that they wanted to breastfeed, many wanted to exclusively breastfeed, and then they were hit with constant barriers in this process of sort of deciding on how they wanted to actually feed their infant. In the second aim, this is sort of just quickly throwing up here some feeding statuses at pediatric visits. And you can see at the top, it's exclusive breastfeeding, which is a low proportion, and at the bottom, exclusive formula feeding, which increases over time. And then finally, at the end, the third aim was sort of looking at what's going on in the hospitals. And I will just say in one sentence, people are getting formula at the hospitals. And so if you're looking at why are people not exclusively breastfeeding, for example, provision of formula at the hospitals, it's being very readily available, is certainly impacting that. So really, I think these findings will be used in the community to directly sort of inform interventions moving forward. I would consider this to be a formative research study. And thinking about this at multiple levels, especially within the healthcare system, I think is really important, and kind of zooming out, because there's a lot of conversation at that individual level of those individual feeding choices, but there are so many factors that are informing this. And I think supporting breastfeeding is a real collective responsibility. So thank you.
I just want to thank all 4 of the student presenters again. So Brooke, Arman, Molly, Audrey, thank you for sharing your work with us today, given you're all at different periods in your life. I want to open the floor for questions in your dissertation life. Let me go ahead and open the floor for questions. Yeah, the floor is open. If the students want to come on up here, because I think for Zoom to be able to hear, you have to speak into this mic if you don't mind. Questions from the room, and I'll also monitor on Zoom as well. Questions from the room. Brandon.
When was the 4th visit that you?
Yeah, that's a good question. So that's like between 4 and 6 months. Yeah.
So it's actually for Brooke, I think. So it used to be true, and this is what I don't know because this is not my area, that when babies were born of low birth weight or they thought they were maybe preterm, that they didn't get vaccines at birth.
Yeah.
Is that still true, and is that part of the puzzle, or have we moved forward from that? And how much of that is clinical uncertainty?
Yeah, no, that makes sense. So I know some babies who are still low birth weight at certain thresholds, and this isn't kind of my area of expertise, still don't receive their birth dose vaccines, which is fine. They wait until a later time to get those vaccines. And there are different recommendations based on like, you know, if the recommendation is within 48 hours, but they're this birth weight, then you wait until this time and then you go to 48 hours. So that isn't quite part of the puzzle. I know there's also though some perceptions around children, if they're not feeling well, not getting vaccinations kind of at other times. So there is a lot of like reticence from health workers to vaccinate a child if they're not healthy, and for a parent to get vaccines for their child if not healthy. But yeah, I think that that's an important point, but not kind of part of the puzzle of kind of some of the gaps that we were seeing. Thank you.
Yeah, so my question is to you only. For your study, I just want to know like what percentage of these deliveries were the home deliveries, and were we able to interview some of these women just to understand some of the reasons why like such a large proportion of deliveries are being done at home, because this is directly related to like more and more zero vaccination.
Yeah, no, it is indeed. And I'm still analyzing some of the findings. So actually we asked quite a few questions about maternal health and whether they sought care at home. And so we didn't focus only on caregivers who gave birth at home, but we did focus on areas where there was really high percentages of home births and high percentages of zero dose as well. So we looked at kind of some of the reasons. A lot of them were cost related. You know, they were areas that were remote, rural, they were quite far, difficult to get to the facility. And then sometimes because they had these issues with vial size, they wouldn't be able to go back to the facility. They say, okay, you can come on this day to get your birth doses, but then if they were out, it was harder. So there was kind of that timing point that, you know, came a challenge as well. But those are some of kind of really understanding those drivers of home deliveries is something I want to tease out as we get a little bit more into the analysis. Thank you though, that was a good question.
Yes, I thought Sherry and then.
Yes, my question was, can you tell us a little bit more about the healthcare providers and how it affects the moms that are breastfeeding? Are they actively encouraging moms to breastfeed and then providing formula when they're unsuccessful, or is it more like they're just skipping over encouraging them to breastfeed going straight to formula?
Good question. Yeah. So you're talking sort of at the hospital post-delivery.
Yes.
Yeah. So we're seeing both in the interviews. So that was one of the things that was emerging that we tried to refine a little bit to tease apart, because those two things are a little different in terms of, was formula just being offered immediately or suggested immediately, or was it based off of someone really struggling to breastfeed? And it's both. Honestly, we were seeing both. So some women were successfully breastfeeding and were offered formula. Others were struggling, and then I would say probably were not adequately supported in their journey, and then were offered formula. I think it's a little bit of both. Yeah.
So thank you for these 4 accelerating talks. It's really fun to hear all that's going on. I have a question for Molly and Brooke. Both of your dissertations are addressing vaccine delivery, vaccine receipt, and whether you've been able to expand your view to some nutrition services that follow those same demographics. For example, Molly, there's a global movement toward multiple micronutrient supplementation being given to pregnant women. Service, access, service, receipt, some of the same implementation research kinds of questions that relate to getting a vaccine or getting a bottle of supplements. Any attention to that activity, and to Brooke, it's sort of a similar thing. You see the vaccine rates going down. 7% of those who got one was only BCG. It's almost vaccines are plummeting. If that's the case in Madagascar, which one can understand because of the rural structure the way it is. But vitamin A supplementation remains the only proven treatment for measles in terms of reducing case fatality. Any expanded view in terms of whether children are getting their vitamin A if they're not getting the measles vaccine?
go first?
Yeah, sure. Yeah, it's a really great point. Our study did not include questions specifically about other programs that are linked into vaccine delivery, and recognizing reaching women at the right time with the right vaccine when they happen to be in a clinic is a really key question here and challenge. But the question about integration, I mean, that is a very big push right now, and a particular opportunity, I think, with maternal vaccines, as we have so much work to do to start sensitizing communities, decision makers, others along that continuum. There is a real opportunity to link in some of these other interventions, and is perhaps something, I mean, I'm at the point where I can kind of put some things still in. We're developing the instruments for that third aim about how the decisions are made, and it maybe is something to ask about how they think about integration across other MCH interventions. Thank you.
Happy to talk to you.
Perfect, that'd be great.
Yeah, thanks very much for the question. The short answer is yes, we have been thinking about that. Actually, it wasn't the work that I presented, but so this work is supported by USAID under the MCGL project. And we're actually doing another analysis in Madagascar where we're looking at the combination of zero dose status and wasting. So we've really been looking at some of the nutrition interventions, looking at vitamin A specifically. And then some of the work, I didn't focus on it today, but on the first two aims that look at that multi-zero dose, as I'm calling it now, that'll incorporate some of those nutrition indicators as well. So especially vitamin A for sure. So yeah, we've been looking at that, and actually it was interesting to see in Madagascar, there was a lot of correlation between the children who didn't receive vitamin A and who were zero dose. That's understandable since it is administered at some of the same time points. And yeah, for your point on measles as well, just one thing to note, what we were looking at was children 12 to 23 months in the analysis. So measles would have come kind of towards the end of that. So there would be a little bit less time, but yeah, it still was showing that BCG, of the children who got only one vaccine, I was a little bit surprised to see that they were reached by BCG and not something with a campaign delivery. Yeah, thank you.
Great. I think there's a question online. Brandon, do you want to read it out loud?
This is from Andres Ficino, from Brooke.
Yeah, I can see it.
So the findings from the qualitative data seem to be related to supply side issues, and one of them from the demand awareness. Is there anything that also signals perhaps some level of vaccine hesitancy?
Yeah, so this question's asking, in case folks online couldn't hear it, or I guess you can see it, so about vaccine hesitancy. So actually what's interesting, we're still teasing through some of the analyses, but we didn't really see birth dose specific vaccine hesitancy. There is some vaccine hesitancy in Madagascar, especially with COVID vaccines and some of those kind of recommendations being a little bit unclear in some areas. So there's kind of overall hesitancy, but we weren't seeing anything that was specific to birth dose or specific to, vaccinating babies when they're really young, or anything that kind of came in, conflict with the services mothers and families wanted their children to receive at birth. So yeah, thank you.
Thank you, Brooke. I think we have one more question, Greg.
Yeah, so this is a question for Arman and Audrey. So I think what was very unique about what you both are doing in your work is you're not just talking about how individuals interact with interventions, you're talking about sort of the interaction between like the whole institution of an intervention. So it's like how are implementers, in Audrey's case, like formula feeding companies, Arman in your case, the implementers of cookstoves, how are they interacting with people over time? And I guess from this whole body of work and what you've learned so far, what kind of insights have you been able to derive or recommendations about sort of other ways that implementers can more responsibly interact with, I will say, the end users or beneficiaries of the technologies that they're receiving that are maybe outside the scope of your work? So Arman, you sort of focus on cookstove, Audrey, infant feeding. So are there areas for learning from your work that are sort of outside the scope of those individual pieces?
Yeah, it's a question. I would say that the funding piece what I've been sort of finding, and as I've been going through it, doing the archive analysis, and it is outside the scope of my work because it deals with a level of sort of understanding that I can't get into because I want to focus on the project itself. But the way that sort of funding calls are structured make it really difficult for investigators who are applying for those sets of funds to formulate projects which could be responsive to the community, because especially in this case, it was fairly well specified what they were looking for, what the funders were looking for. Even though they sort of said that community engagement was important, it sort of left up to the interpretation as almost a checklist activity to the investigators to figure out what that is. So as far as my sort of research goes, what I find is that there should be more of a, what I'm hoping is that from my results, I don't know what the final form will look like, but from them that we can sort of make perhaps calls that are a little bit more responsive, allow for a little bit more of a formative component to be incorporated into the research.
Takes me some time to think. I'll be able to answer this question better in my defense, but two things came to mind. Date TBD. Okay, soon. Soonish, yes. Two things are coming to mind. One is sort of the baby-friendly hospital initiative. So these are evidence-based interventions within the healthcare system, in this case, around the time of delivery to support breastfeeding. None of the hospitals where I was interviewing key informants were baby-friendly certified. So when this happens, it's sort of dependent on the individual clinicians and sort of clinical judgment or how much time they have, or their biases, or, you know, when you don't have policies, it becomes an individual thing, I guess. The second that comes to mind is sort of agency. So the agency of a parent to feed their infant in the way that they want to. And that's the hard one that I really need to mull over a lot, because it's really important to support parents. And you have a lot of these forces that it's sort of that idea of breastfeeding intent, where when you're making a decision, you're taking into account the fact that you have to go back to work in 3 weeks. You're taking into account, you know, perhaps like, I mean, that's a big one, but there's lots of different barriers. And so that's kind of something that I'm wrestling with. And that's why I think focusing on this collective responsibility aspect of, can we set people up to be supported? And you have a lot of factors and a lot of forces and capitalism pushing and pushing and pushing. And so that's really hard to grapple with and still respect, you know, but in this case, a mom or a new parent doing the best she can with the hand that she's dealt. So that's hard. I don't know. Hopefully I can articulate that better in a few months, but that's what I'm wrestling with right now.
Great. Any other last questions? Oh, yeah.
Vaccines. For the breastfeeding, there is a seminar working in economics where they looked at when the kids was born. So kids who were born during the weekend because the social worker was not in the hospital at that time. They looked at exogenous variations. So
Yeah.
maybe you can look at calendar and see if that is the place, because it's a matter of
That'd be interesting.
higher likelihood of kids working during the weekend
Yeah.
at a certain hour.
I saw a little bit of that with when the certified lactation consultants were on shift. So they only worked in the days. Babies are born round the clock. So that's going to immediately influence the level of support that someone could have if they're struggling quickly. So yeah, that's a good point.
And the second issue, Brooke, you said that they don't want it to open the bill because they come by 20. So
Yeah.
that's usually a problem that it's like, it seems to me that then what you're supposed to use in the system is something that is
Yeah.
more according to the demand. We cannot have these sales here of cheap babies.
I know.
Why
It-
we keep having-
Yeah. No, I completely agree. Yeah, I feel like that's something that a lot of people in the vaccine world have been kind of thinking, you know, we could get smaller vial sizes, we could do something that really, you know, tailors to these communities better. I think it's a hard thing to either advocate for, especially advocate for at the pharmacy side. But I mean, it definitely is a challenge. Some countries have introduced smaller doses, like 10 doses, but we would still, you know, be up against some challenges there. But yeah, that I agree that that's a challenge. I think our solution's pretty simple. I'm a little biased.
Well, I want to thank everyone for coming today. I want to give a big hand to all the students. Audrey will send out once we know her dates.
Yeah,
Please like that.
Yeah.
But thank you everyone. In touch.
Yeah,
Exactly.
on the way out. Answer that question again.
You might not be able to-
Oh, yeah, should we stop? Let's just shut this down.
Arman, you got it?